And you know that when the muscle is stretched, the spindle is also stretched and it's activated, so action potential is made in the fibers, in sensory fibers, and goes to the spinal cord. And we have seen in the last session that in the spinal cord it has two branches, right? One branch directly connects the alpha motor neuron that goes to the same muscle, the stretched muscle. So we have a monosynaptic pathway here that causes contraction of the same muscle. The second branch activates an interneuron. This interneuron is inhibitory GABAergic. So it inhibits alpha motor neurons that goes to antagonist muscle. So the muscle under the stretch contracts, but the opposite muscle relaxes, right? So the result is movement of the knee this way, in the way of extension, right? And I told you that we have also type 2 fibers from the muscle spindles that go to the spinal cord. Actually, they are not shown here, but they activate other interneurons here that do the same function, activation of alpha motor neuron to the muscle of the stretch, and inhibition of alpha motor neuron that goes to the antagonist. So this pathway is polysynaptic or disynaptic. So this is the network, the neural network for generation of stretch reflex, right? So, in the brain, in the brain stem, in pons, we have a region called bulboreticular facilitatory region. So, bulboreticular facilitatory region, it's located in the pons. So, neurons that originate from here go down through the spinal cord and reach the neurons that are involved in a stretch reflex, right? So the same neurons, neurons that are located in the pons are activated by the cerebellum, vestibular nuclei, basal ganglia, and cerebral cortex. So they are activated. Then they go to the they go to the spinal cord. In the anterior horn, they activate gamma motor neurons. So gamma motor neurons innervate intrafusal fibers, you know that, right? So the two ends of muscle spindle contract. The middle part is stretched, right? Action potential is made in 1A and type 2 fibers. They go to the spinal cord, cause a stretch reflex, right? So alpha motor neurons from the spinal cord come back to the muscle, cause contraction of the muscle. So what is the result? When this region in the brain is active, muscles are partially contracted, right? So gamma motor neurons are activated by this region in the pons, bulboreticular facilitatory region, right? They go to the muscle spindles, activate the muscle spindles. Muscle spindle is connected to the spinal cord and it activates alpha motor neurons. Alpha motor neurons cause contraction of the muscle. So we'll have partial contraction of the muscle, which is called the tone of the muscle. Yeah, muscle tone. Muscle tone means the degree of stiffness that is present in a muscle during the resting state. So in the resting state, we have some stiffness in the muscle that is caused by partial contraction of the muscle and is called tone. This tone is made by bulboreticular facilitatory region. Actually, other centers are also involved, but this one is related to our topic today, right? So bulboreticular facilitatory region activates muscle by way of gamma motor neurons. And this way they cause tone of the muscle. So this way you can say that stretch reflex is also involved in maintaining posture of the body. Posture of the body means the general position of the body, right? So for example, we are standing or sitting or lying, right? So this is the posture. So, for example, when I was standing here and all of a sudden I actually tilt back, then what happens? Some muscles in the anterior part of the body are stretched, right? They cause a stretch reflex, so they contract, right? So because of the contraction of this muscle, the body comes back to the resting position, original position, right? So we can say that stretch reflex is involved in two very important functions of the brain. First one is maintaining muscle tone. The second one is maintaining posture, right? So this is a function, physiological function of the stretch reflex. Now let's start the second reflex, Golgi tendon reflex. Remember that in the muscle we have two types of receptors, muscle spindles and Golgi tendon organs. Golgi tendon organs are located in the tendon of the muscle, right? So, Golgi tendon reflex means relaxation of a muscle when it contracts strongly. So, let's remember, if we stretch a muscle, it contracts. So this is the stretch reflex. Now, if a muscle contracts strongly, it relaxes. It is relaxed, right? So this relaxation is called Golgi tendon reflex. So the receptor for this reflex is Golgi tendon organ located in the tendon of the muscle, right? So let's see how this happens. Here we have the muscle, skeletal muscle. So at the junction of the muscle and the tendon, we have the Golgi tendon organ. So let's see a larger view of this here. So this part of the muscle is shown here, right? So we have muscle fibers here and tendon here. So here we have a Golgi tendon organ, so a receptor. So it has a shield, and inside this shield it has some fibers. These are collagen fibers, right? So, and here you can see that there is a type 1B fiber that originates from cells from DRG. They go to this Golgi tendon organ. It has several branches, right? The branches of this fiber is located between the collagen fibers, right? Now, what happens if the muscle contracts? If the muscle contracts, tendon is tensed, right? Is stretched, and the collagen fibers are stretched. What happens to the nerve tips? They become under pressure, right? So they are pressed by these collagen fibers. So an action potential is made and goes to the spinal. So when Golgi tendon organ is activated, when the muscle contracts, right? So that's why we say that these receptors are sensitive to tension of a muscle or force of a muscle. So it's different from muscle spindle, which is sensitive to the length of the muscle, right? So if the muscle contracts, these collagen fibers are tensed, the tip of these nerve fibers are activated, then we'll have action potential that goes to the spinal cord. Through which fiber? 1B, sensory fiber. So remember that for stretch reflex, we have 1A and type 2 sensory fiber, but here we have 1B fiber. So it goes to the spinal cord, it activates an interneuron. So the name of this interneuron is 1B inhibitory interneuron because it's connected to 1B fiber, right? So this is an inhibitory interneuron, so it inhibits alpha motor neurons that goes to the same muscle. So when muscle contracts, Golgi tendon organ is activated, action potentials goes to the spinal cord. In the spinal cord, they activate interneuron. Interneuron inhibits alpha motor neuron. Alpha motor neuron doesn't activate muscle fibers. So the result is relaxation of the muscle. So when the muscle strongly contracted, when the muscle is contracted strongly, right? The result is relaxation of the same muscle. So this way it can protect the muscle from tearing down, from rupture, from actually, yeah, from separating from the bone or dislocation of the joint, right? So when the contraction is very strong, all of this may happen. And this way, this reflex is a protective mechanism to protect the muscle, right? Okay. So remember that this word is a key word here, right? Tension. Tension means force on a muscle. So when force goes up, Golgi tendon organs are activated, we'll have relaxation of the muscle, right? So the next reflex is flexor reflex or withdrawal reflex, right? So let's see. A strong cutaneous stimulus to the limb causes flexion and withdrawal of the limb, right? So if we touch something very hot, suddenly we remove our hands, right? So what happens here? Because of this pain stimulation, a flexion happens in the arm. So that's why we call this flexor reflex. At the same time that we have flexion, the hand is withdrawn from the hot object. So withdraw, right? So we actually get our hand back from the object. So this is called withdrawal, right? So at the same time that we have flexion, we have also withdrawal. So that's why we have two names for this reflex. Flexor reflex or withdrawal reflex. Remember that receptor for this reflex is not located in the muscle. For a stretch reflex, spindles are in the muscle. For Golgi tendon reflex, GTOs are in the tendon of the muscle. But here the receptors are in the skin, right? They are pain receptors actually. So when we have pain in the hand, right, sudden pain. So action potentials go to the spinal cord, activate the population of interneurons. These interneurons activate alpha motor neuron to the flexor, inhibit alpha motor neuron to the extensor. So flexor interacts, extensor is relaxed. The result is flexion, right? So the key word here, or the key concept here, is that the receptor is in the skin, and fibers carry action potential to the spinal cord. In the spinal cord, we have several interneurons. Some of these interneurons are excitatory, others are inhibitory. Inhibitory interneurons inhibit alpha motor neuron to the extensor. Excitatory interneurons activate alpha motor neuron to the flexor. Right? So this is called flexor reflex. Sometimes, when the flexor reflex is very strong, the opposite pattern happens on the opposite limb. So we have flexion in the arm, in the ipsilateral arm, we have extension on the opposite arm. Right? So let's see. Okay. So because of the pain in this arm, we have flexion of the same arm, but some neurons go to the opposite side of the spinal cord, activate another population of interneuron there. Again, here we have excitatory and inhibitory interneuron, right? But the opposite pattern happens here. Alpha motor neuron to the flexor is inhibited, but alpha motor neuron to the extensor muscle is activated. So the result is extension. So now imagine that we are moving, right? We are walking, and suddenly we hit our leg to an object. So we feel pain, right? And suddenly and very fast and immediately we withdraw our leg, right? So we have flexion. So at the same time that we have flexion, signals go to the opposite side, cause extension on the opposite leg. This extension helps us to keep our weight because we actually lifted our leg, the weight should be kept, right? How this is kept? By extension of the opposite leg, right? The same also happens in the arm, usually when the stimulation is strong. And in this type of reflex, we have also a spread of the signal upward and downward. Maybe we have actually stimulation in the leg, but at the same time that we have flexion in that leg, we also remove our body from the object, right? When the object is very actually hot or very painful, then all of this happen. Flexion of the same leg, extension of the opposite leg, removal of the body, right? And remember from our previous session that we had three type of organizations in the spinal cord: segmental, propriospinal, and descending, right? For the spread of the signal from the leg to the arms, we need propriospinal neurons. So propriospinal neurons that connect several segments together are involved in this spread of signal from the legs to the arm, right? So the extension that happens in the opposite leg is called cross extensor reflex. So after a painful stimulation in the arm, we have flexor reflex in the same arm, but cross extensor reflex in the opposite arm, right? At the same time, we have a spread of the signal upward and downward. So maybe the arms, the legs, and also the body are involved in this reflex. Got this? Good. Okay. So we have seen three of these reflexes: stretch reflex, Golgi tendon reflex, and flexor reflex. Right? All of these reflexes are actually coordinated and organized by neurons in the spinal cord. So the neurons are in the spinal cord, right? So these neurons usually receive descending pathways from the brain, right? So from the brain, fibers start, go down through the spinal cord, reach these neurons, and actually regulate the sensitivity of these neurons. So although these reflexes are automatic and they are made without decision, without thinking, right? But they are usually regulated by descending pathways, pathways that originate from the brain. So now imagine that a traumatic injury happens in the spinal cord. For example, after a car accident, right? So some of these fibers that go down through the spinal cord are cut. So neurons that are located below the cut actually will lose their regulation through the brain. So their sensitivity is lost, right? Now, we may have a stretch in the muscle, signals come to the spinal cord, but the neurons were already insensitive and unresponsive to the signal. So we won't have reflex, right? Or maybe we have a painful stimulation to the body, signals are made through the receptors, come to the spinal cord, but when they reach the neurons, these neurons actually have already lost their sensitivity to these signals. Why? Because we have injury upward, right? So, you can say that after an injury to the spinal cord, descending pathways are interrupted. They cannot regulate neurons below the cut. The neurons here will lose their sensitivity, so all reflexes are gone, right? So we may stretch the muscle, we won't see stretch reflex. The muscle contracts strongly, Golgi tendon reflex doesn't happen. We may have pain, but flexor reflex doesn't happen. So all reflexes are lost. So this situation is called spinal shock. So a spinal shock means loss of all reflexes that happens after injury to the spinal cord. But remember that we have somatic reflexes and also autonomic reflexes. Reflexes that involve internal organs, like baroreceptor reflex, right? So these receptors are also lost. So baroreceptor reflex is involved for regulation of blood pressure, right? So when these reflexes are lost, blood pressure also goes down. So at the same time that all reflexes are lost, blood pressure also goes down very strongly and severely, right? So blood pressure may reach 14 millimeter mercury. It's very low actually. Instead of 20, it's about 40, right? So all reflexes are lost, blood pressure goes down, right? And actually, uh, emptying of the bowel, the colon, and emptying of the bladder are also lost because they are actually controlled by reflexes that organize in the spinal cord. So spinal cord is also important for emptying of the bowel and emptying of the bladder. So when we have injury in the spinal cord, these reflexes are also lost, so the patient cannot urinate, cannot defecate. Right? So this condition is called spinal shock. After some time, usually these reflexes come back again. For example, in humans after 2 or 3 months, right? Because I told you before that when we have a synapse and this synapse is actually is experiencing underactivity, hypoactivity, they increase their sensitivity. We call this upregulation. So the number of receptors increase, so the synapse becomes more sensitive, right? Or when we have hyperactivity of a receptor of a synapse, we'll have downregulation of receptors. Because of this downregulation, the activity of this synapse decreases. Now, in this patient, we have hyperactivity because reflexes are not working, right? So, in response to this hyperactivity, we'll have upregulation of receptors in a synapse. Because of this upregulation, after 3 months, usually reflexes come back again, right? So we'll have spinal shock only for 2 or 3 months. So it's temporary. And after that, we'll have a phase of supersensitivity of reflexes. Okay? So any questions so far? Anything is clear? Okay. So the second part is about brainstem and motor cortex, right? So you know that brainstem is composed of medulla, pons, and midbrain. To the back of these, we have cerebellum, right? So in the brainstem, we have some centers that are responsible for regulation of cardiovascular activity. So you know that, right? Because you have passed actually circulatory blood, and you know that, yeah, actually the heart physiology, right? So you know that we have some centers in the medulla and pons related to the regulation of cardiovascular function. We have also other areas related to GI functions. For example, chewing, swallowing, right? So these centers are located in the brainstem. Also in the brainstem, we have respiratory centers, right? So they regulate inspiration and expiration, right? So these are some centers that have motor functions, but you know them actually. Today I want to talk about something else in the brainstem. So we have several areas in the brainstem, in the reticular formation, that are important for control of posture of the body, right? General position of the body. So let's see the centers. So in the pons, we have pontine reticular nuclei, these two. In the medulla, we have medullary reticular nuclei, right? So between the pons and medulla, we have 4 vestibular nuclei. So vestibular nuclei are these, right? So we have inferior, superior, lateral, medial vestibular nuclei, right? 2 medullary reticular nuclei, to pontine reticular nuclei. So from these neurons, we have axons that go down through the spinal cord, right? So from these two, we have pontine reticulospinal tract. So pontine reticulospinal tract. Let's see here. In the spinal cord, in the anterior side, this red region, okay, is pontine reticulospinal tract. It starts from reticular formation of pons and goes to the spinal, right? So it travels in the anterior part of the spine. So we have two on each side, right? So we have medullary reticular nuclei that are origin of the medullary reticulospinal tract. Let's see here, medullary reticulospinal tract, right? So from here, from this one, we have two pathways: lateral vestibulospinal tract and medial vestibulospinal tract. So from these nuclei, we have two tracts: lateral vestibulospinal, this one, and this one is medial vestibulospinal. This one originates from this nucleus, right? And this one, the orange one, originates from this one, right? So we have lateral vestibulospinal tract, medial vestibulospinal tract. So from now, let's clear something for you, and then we will continue, okay? Pontine reticulospinal tract and vestibulospinal tract are excitatory, but medullary reticulospinal tract is inhibitory, right? So these nuclei cause contraction of the muscles, right? But this one causes relaxation of the muscle. So the action of medullary reticulospinal tract is relaxation of the muscles. But the action of vestibulospinal tract and pontine reticulospinal tract is contraction of the muscles. Which muscle? Remember from our previous session that we had lateral medial divisions, right? In the ventral horn, we had some alpha motor neurons that were located laterally. They innervate distal part of the body, right? And I told you that we have alpha motor neurons located on the medial side. They innervate proximal part of the limbs and axial muscles, truncal muscles, neck muscles, muscles around the spine, right? So all of these neurons innervate medial alpha motor neurons. So they go to the spinal cord, they reach medial alpha motor neurons. Medial alpha motor neurons contract proximal part of the body, axial muscles. Generally, we call them anti-gravity muscles. So anti-gravity muscles are muscles that lift our body against the gravity. So they cause a standing position, right? So these inhibit these anti-gravity muscles, but these cause contraction of the anti-gravity muscles, right? So now let's see some more details. Here, pontine reticulospinal tract, right? They originate from reticular formation of the pons. They are highly excited, so neurons here are very active. They receive a strong excitation from vestibular nuclei, cerebellar nuclei, ascending sensory fibers of the spinal cord. They go through pontine reticulospinal tract down the spinal cord. They reach medial alpha and gamma motor neurons. They innervate axial muscles, proximal muscles, right? I told you all of this. And then they cause powerful excitation of anti-gravity muscles throughout the body, right? So they regulate basic tone and support posture. So in the first part of this session, I told you that in the pons, we have bulboreticular facilitator region that goes down, which has gamma motor neurons. Gamma motor neurons activate muscle spindles, right? Muscle spindles activate alpha motor neurons. Alpha motor neurons cause partial contraction of the muscles. I told you, this is called tone, right? So stretch reflex was involved in tone of the muscle. So this region in the pons is the same region, bulboreticular facilitatory region. So bulboreticular facilitatory region is the origin of the pontine reticulospinal tract. Got this? So this is the same region. So now we have medullary reticulospinal tract. I told you it's inhibitory, right? So this tract originates from medial reticular formation of the medulla, nucleus gigantocellularis. It receives a strong input from cortex to corticospinal tract, from red nucleus to retrospinal tract, and other pathways like this again. They transmit inhibitory signals through medullary reticulospinal tract in the ventral lateral folliculus. They end on interneurons, inhibit medial alpha and gamma motor neurons, so they cause relaxation of axial and proximal muscles, right? So they counterbalance the activation that is made by pontine reticulospinal tract. So pontine reticulospinal tract contracts the muscle, medullary reticulospinal tract opposes this contraction, relaxes the muscles, right? So we have always balance between these two pathways, pontine and medullary reticulospinal tracts. So we had also 4 nuclei called vestibular nuclei. They were the origin of lateral vestibulospinal, medial vestibulospinal tract, right? So let's see the lateral one. It originates from lateral vestibular nucleus. The other name is diater nucleus. Okay. So they receive excitatory inputs from semicircular canals and otolith organs from the internal ears. So from internal ears, we have signals that originate from vestibular apparatus. They go to vestibular nuclei. Vestibular apparatus is important for detecting any change in the balance. So when we bend forward, backward, to the right, the left. So when the balance goes out, actually bent out, right? Then what happens? Internal ears is activated. Which part? Vestibular apparatus, right? From here, signals are made, go to vestibular nuclei. Vestibular nuclei are origin of the vestibulospinal tract. They are connected to the muscles, right? So they cause contraction of the muscle. So when we go out of balance, this system is activated, cause contraction of the muscles. Which muscles? Anti-gravity muscles, proximal muscles, axial muscles. Because of the contraction, body position come back to the balanced state, right? So, excitatory inputs from semicircular canals and otolith organs, and also from Purkinje neurons. Okay, ignore this. They descend ipsilaterally through the ventral follicles, terminate at all spinal levels. They end on interneurons, activate alpha and gamma motor neurons, cause contraction of truncal and proximal extensor muscles. They inhibit flexor muscles. So flexors are inhibited, extensors are contracted, right? So the result is postural adjustments after angular and linear acceleration. So when we have acceleration, means, for example, when we enter an elevator and goes up very fast or go down, or we are sitting in a car and move forward very fast. or our body bends forward or backward. So this is acceleration. So whenever we have acceleration, this system is activated and keeps our balance, right? So lateral vestibulospinal tract. This one, medial vestibulospinal tract. Okay, from medial vestibular nuclei. So they also receive input from semicircular canal. They descend bilaterally, right? They reach cervical and mid-thoracic levels. So there is one difference here and with a lateral vestibulospinal tract. The lateral vestibulospinal tract is connected to all levels of the spinal cord, but this one is connected only to cervical and mid-thoracic levels. It doesn't go down more, right? So it only contracts muscles in the upper part of the body, muscles of the neck and muscles of the trunk, right? So this pathway is mainly involved for making movements in the head when we are out of balance. So, for example, when we have angular acceleration, so you're driving a car and you turn around very fast, right? So because of this angular acceleration, this system is activated. So you're turning this way, okay? At the same time, your head moves this way. Why? Because it tends to keep your body balanced, right? So this is the function of the medial vestibulospinal tract, right? So it ends on interneurons. Interneurons activate motor neurons. They go to extensor and flexor muscles of the neck. They cause adjustments in head position in response to angular. Got this? So, the last tract I mentioned for you is temporospinal tract. It originates from the midbrain, from superior colliculus. Right? So the origin of the neurons are in midbrain, superior colliculus. Right? So they cross the midline, go to the opposite side. They descend in the ventral colliculus of the spinal cord. They terminate on medial group of interneurons in the upper cervical spinal cord. Again, in cervical region of the spinal cord. So they are related to movements of the neck and eyes. Right? So they regulate head movements and eye movements in response to visual, auditory, and somatic stimulation. So there is one difference between this one and medial vestibulospinal tract. Medial vestibulospinal tract is activated when we go out of balance, right? So the signal should be something related to balance of the body. But here, the signal is not balance. It's visual, auditory, and somatic stimulation. So we're looking this way, right? Suddenly something moves from the peripheral side. For example, a mouse goes very fast. Okay, what happens? Eyes and head actually move toward the stimulation. So we suddenly look at that way. Right? Why? Because something happened there. So and stimulation happens in the peripheral region of the visual scene, right? Head and eyes change the position and they go to the side of the stimulation, right? So visual stimulation, auditory stimulation, or somatic stimulation cause movements of eyes and head, coordinated movements of eyes and, so this is a functional temporospinal. So let's summarize. We have several tracts that originate from the brainstem and goes to spinal cord, right? We have from pons, we have pontine reticulospinal tract. It activates anti-gravity muscles, right? From the medulla, we have medullary reticulospinal tract. It causes relaxation of the anti-gravity muscles, right? We have two pathways that originate from vestibular nuclei. lateral vestibulospinal tract, medial vestibulospinal tract. The lateral one is for keeping the posture and keeping the balance, right? But the medial one is for movement of the head and neck when we go out of balance, right? The last one was tectospinal tract that originated from superior colliculus in the midbrain. They cause coordinated movements of the eyes and neck when we have a stimulation in the peripheral region. This stimulation is maybe visual or auditory or somatic. So if somebody touch you, right? Head and eyes move toward the stimulation, right? Tectospinal tract. So, any question here? No, actually I'm talking very fast because I want to cover several things for this session actually because it's the last one, right? So, let's see the motor cortex, and after 10 or 15 minutes we will have a break, right? So, motor cortex. Remember from our previous sessions that movements are of four types: reflexes, rhythmic movements, postural movements, and voluntary movements. We have seen reflexes and postural movements, right? Reflexes are actually organized by spinal cord, right? Yeah, postural movements are organized by brainstem. We have seen several tracts, right? Now, let's see motor cortex, which is important for voluntary movements, purposeful movements, right? So, in the brain, in the cortex, we have several areas related to voluntary movements. They are located here. So you know that in the brain we have frontal lobe, right? We have parietal lobe, occipital lobe, and temporal. So the border between the frontal lobe and parietal lobe is this feature, central feature, right? So anterior to the central feature, we have precentral gyrus here. So we have also postcentral gyrus, right? Which is somatosensory area 1. Remember, it is Brodmann area 1, 2, and 3, right? And we had also Brodmann's area 5 and 7 that were somatic associational areas, right? So they are located in the parietal lobe. But anterior to these areas, we have motor areas. So it's located in Brodmann area 4 and 6. So Brodmann area 4 is called the primary motor cortex. But Brodmann area 6 has two parts. An upper part called supplementary area, a lower part called premotor area. So we have primary motor area, premotor area, supplementary motor area. All of them are important for purposeful movements. They are located in the frontal lobe. They cover Brodmann area 4 and 6, right? Now, in the primary motor cortex, we have a map of the body, similar to the map that we have in somatic area, right? So the mouth and face are represented laterally, but the legs and feet are represented medially. So feet and legs are represented medially between the hemispheres, right? But face is represented laterally, right? So what do I mean when I say they are represented? So we have some neurons related to legs between the hemispheres. If we activate these neurons, what happens? We'll have a movement in the legs, right? So now imagine that we stimulate neurons that are related to the face, right? When neurons related to face are activated, we'll see a movement in the face, right? So they cause contraction of muscles in the face. But remember that we have contralateral connections. If we stimulate neurons on the right side of the brain, the movement happens in the left side of the body. If we have a stimulation in the left side of the brain, movement happens on the right side of the body. So if we stimulate neurons here, in the hand area, on the left hemisphere, so we'll see a movement in the right hand. Right? Got this? So, now let's see more details about the primary motor cortex. You can see one side of the brain, right? So here we have medial region, which is located between the hemispheres. Here you can see the lateral region. So similar to somatic area, you can see that the area related to the face and the fingers and hand is very large. But the area for body, the thigh and the legs is very small, right? So we have a small face, small hands and fingers, but the cortical region for these areas is very large. We have large body, but the cortical region that innervates the body is very small. Why? Because most of our functions, most of our movements are made by fingers and face. For legs, we have a small number of movements. For example, we only walk, right? Or we maybe, for example, hit a ball, okay? So the number of movements that we can make with our legs is very small. So we need a few neurons in the brain. But the number of movements that we can make by fingers is very high, right? So we can touch something, we can write, we can scissor, we can cut, we can hammer, right? We can use screwdriver. So several functions are made by hands and also by face because we talk with our face, with our lips. And speaking is very complex movement, right? So we need a very large area in the brain for control of movements in the face and hands and feet. Okay. So let's go on. What aspect of movement is controlled by primary motor cortex? Here. If we stimulate neurons weakly, we'll see only a twitch, right? A twitch-like contraction of the muscle happen. Usually we call this discrete movement. So discrete movement is a movement that has a beginning and an end, right? So this is discrete. But if we stimulate it stronger, we'll see a complex movement. Complex movements usually involve several joints, right? So like this one, or like this one, okay? So we use shoulder, elbow, wrist, fingers, right? So this is a complex movement. So weak stimulation of neurons in the primary motor cortex causes discrete movement, right? But strongest stimulation here causes complex movements. So what aspect is regulated here by M1 neurons? M1 means primary motor cortex, like S1, right? So muscle force, muscle length, the number of muscles activated, joint displacement, force and trajectory of movement. So all of these are controlled by primary motor cortex. What is trajectory or direction? For example, I want to actually pick up this, right? So trajectory can be this, or maybe it's here, this one. Trajectory will be this. So a direct movement or a curve movement. So this is called trajectory, right? So trajectory of movement is also controlled by primary motor cortex. So The next area is supplementary motor area. Remember this sentence, which is very important. Usually, performing a movement or doing a movement is controlled by primary motor cortex. But before that, we should make a decision about that movement, right? And then we should plan that movement. So, decision making happens in prefrontal cortex, but planning of a movement happens in supplementary motor area, premotor area. Execution or performing of a movement happens in primary. So, first we think prefrontal cortex. We make decision, prefrontal cortex, prefrontal, right? Then this decision is converted to a plan. So planning of the movement happens in premotor and supplementary. Then this plan reaches the primary motor cortex for performance, right? So supplementary motor area. Stimulation here causes more complex movements, bilateral movements. Complex movements like bilateral grasping, vocalization, speaking. Complex postural movements, and movement sequence. So the sequence of movement is controlled by supplementary motor area. For example, you want to turn on the radio, right? So first of all, you should have a reaching movement. So you should stretch out for the button, right? Then you should have pressing. Then you should have turning. So reaching, pressing, turning. So it's a sequence of movement, right? So usually planning for this type of movement happens in supplementary. Okay, body-wide attitudinal movement, fixation movements, positional movements of head and eyes. For example, you want to hit a ball, hit a basketball into the basket, right? So you need a body-wide movement. So body-wide movement, I mean postural and positional movement, right? So you get ready for that. You should take a position for that, right? So ball is in your hand, and then you move, right? So the posture of the body before the movement, before the actual throwing of the ball, is called attitudinal movement. Oh, you want to play ping pong, and you are on the back of the table, right? So you keep a position like that, right? So this position is attitudinal. So you have the racket in your hand, and you fix your arm like this. You're ready for the ball, right? So this is a fixational movement, right? So you have postural movement and fixational movements, positional movements of the head and eyes. So all of these are controlled by supplementary motor area. So supplementary motor area is important for complex movement. Yeah. And bilateral movements, body-wide attitudinal movement, fixational movements, positional movements, and sequence. So all of these happen at the level of planning. So these movements are planned here, then they are performed by primary motor cortex. Premotor area. So premotor area is also important for planning of movements, right? So these two areas, premotor and supplementary motor area, are both involved in complex patterns of movement. So when the movement is complex, both of these areas should be involved, right? So setting the posture at the start of the planned movement is controlled by premotor area. But something more, premotor area is important for guiding movements in response to sensory stimuli. Again, guiding a movement in response to sensory stimulation, right? So, for example, you are driving in a road, right? So you reach a region, and then you can see for example, an arrow that tells you you should go this way. So it's green and let you know that you should go this way. But there is a red cross here that tells you you shouldn't go this way, right? So you have two signals, a green one that shows you the direction, a red one that shows you that you're not allowed to come here, for example, right? So you have a sensory stimulation, black, actually a red one and green one, that tells you that your movement should be this way, not that way, right? So guiding movements in response to sensory stimulation. So when you see the arrow and choose to go this way, this planning happens in premotor area of the cortex, right? So from visual cortex, signals reach here, premotor region guides movement to going, for example, to the right, not to the left, right? So this is a function of premotor area. So it makes motor image for planning, and motor image goes to the primary motor cortex for performance. Okay, I think that this is the last one. No. So let's have a break, and after that I will continue from here.